Good day, everyone, and welcome back. In this session, I'm very excited to have Dr. Arshiya Seth of the Cambridge Health Alliance with us today, and she's going to tell us about a unique and very important and innovative program around managing disruptive patients. Welcome, Dr. Seth. How are you?
I'm good, Mark. Thank you for having me.
Absolutely. So would you go ahead, tell us a little bit about your own background individually, your role, title and role at the Alliance, and then we'll talk about the subject matter involved.
Sounds great. Yeah. Well, I am a primary care physician, and I've been practicing for over 10 years now. And one of the other hats that I wear is I'm the medical director of patient safety and risk for Cambridge Health Alliance. And over the last several years, we've had many opportunities to work on projects that involve improving patient care, patient experience, staff experience. And one of our biggest efforts in the last few years has been to create a safe environment for managing disruptive behavior for patients.
Wonderful. And just real briefly, tell our audience about the Cambridge Health Alliance, those who may not be familiar with you.
Yeah. Well, we are a safety net hospital, and we serve the communities of Cambridge, Somerville, Malden, Everett, mostly the Metro North area of Boston. And we have a very wide diversity in terms of patient population, and culturally, we are, even in terms of staff, we are very widely diverse.
Wonderful, wonderful. So, Dr. Seth, I know you wanted to share about a Sentinel event or case that led to this. And even before that, can you define what constitutes a disruptive patient, and then tell us about the Sentinel case that led to this innovation?
Yes. Yeah. Well, so disruptive behavior, this may be a new term for a lot of us, and unfortunately, disruptive behavior can be in any form. It can be a rude email or a my chart message, or it can be in person where a patient becomes, they may shout, they may use obscene words, curse words, or it can be the other extreme where patients can be very disruptive. They can throw things or physically injure property or threaten with a weapon or without a weapon. So it does range from small to very large extent to imminent threat.
Okay, good. And tell us about the Sentinel event or case that led you and your colleagues on this path.
Yeah, well, it was about 3 years ago. We unfortunately had an incident where a patient was stalking one of our providers, and it went on for a while, and ultimately the provider was feeling very unsafe, and the stalking was getting more aggressive. And the patient safety team and the risk management, we worked with the clinic leadership. We were able to terminate the patient from the clinic. However, a year later, the patient returned, re-registered, and became that provider's patient again and established care with that provider. And at that time, we realized that we had several gaps in our existing system. So even though we took that situation very seriously, we were worried about the safety of the provider, we terminated a patient, but we didn't have a structure that made sure that the patient termination was done in a way that it did not allow him to re-establish care with the same provider. We also looked further into our system, and we realized there was no standardized way of closing the loop on such events. The roles and responsibilities of whether it's the leadership person or in patient safety, we weren't clear who is what when such a thing happens. And so
exactly.
that led us to really reflect on our existing system. We did a gap analysis, and we did a failure mode analysis, and we recognized gaps that needed to be addressed right away.
Great. As they say in the business, you had a burning platform. And so how did you have any models at all for this, or did you have to start from scratch? And how did you create and develop the program?
Mhm. Well, we had a lot of resources in place already. So we had things like a flag in our EMR where if we knew that the patient was disruptive, we would flag their record. Or we have a great infrastructure with public safety officers who help us when there is a situation which requires them to come on site and help us. We did have protocols in place for putting a behavior contract with the patient, which is called a continuation of care contract. However, all of this was not united, and we weren't using all the resources together in a timely manner. And I think that was a big aha for us.
Okay. And which people by title, which types of people did you need to bring to the table to create a systemic program?
Yeah, so we have created now a threat assessment group. We call it our TAG group, and that includes me from primary care and medical director of patient safety. We have a psychiatrist who specializes in management of disruptive behavior and addictions. We have our legal counselor there and public safety officers and patient safety risk team. Yeah.
Perfect. And how long did it take to develop the full program, and when did you go live?
Well, our incident happened in October and we were live in March. And it took us a few months because we did study different hospitals and policies from different places to see how other people are managing this. And there were, although there were protocols in place, there was nothing like the threat assessment group that we have created.
Interesting. So now you have the program in place, obviously. Can you say how many patients the team has had to be activated around?
Yeah. So in the last 2 years that we've been working, over 2 years, we've seen about 25 cases. And our program
that's
has
about
run
2 cases, or about a case a month, about?
Yeah. It comes in waves, unfortunately.
I wonder, are there anything like holiday times, or are there period times of the year, or maybe holidays or special events that maybe trigger potentially disruptive patients?
Yes, that's a great question. So unfortunately, we have run in parallel with the COVID pandemic, and that itself has been a major stressor for this vulnerable group of population who, patients who are disruptive, they also have coexisting behavioral health, psychiatry issues. And COVID has led to lack of resources and lack of appointments, and a lot of suffering and death. And I think that has really created these incidents where patients become really volatile and can threaten to come and kill a provider or throw a bomb or serious threats.
In other words, some of the psychological challenges of the pandemic have triggered some patients then.
Very much, yes.
What are the biggest challenges, if any, of carrying out the protocols in the program?
Yeah, it's been, our program has been very successful, but we've also had challenges in terms of where staff may not feel that this is an imminent threat or this is something that should be reported right away. And so I think that teaching and education has been ongoing from our end, where we don't want staff to analyze whether this is an imminent threat or not. If this is something out of ordinary and worrisome, they should report it. And then we are here, and the threat assessment group meets within hours of being told about the threat, and we come up with a short-term safety plan. So
right, exactly, because you're trying to relieve a burden on clinical and other staff, right? You don't want them to feel that they must have the responsibility of diagnosing a threat, right?
Exactly. Yeah. And we are all the right people on the table, from public safety to legal to risk. We are all here, and we know what to do in that moment. So
Wonderful. Have there been any surprises at all as you've executed on the plan?
Well, I think one of the surprises was we felt that we are doing this to help providers and staff, and they will be they will be very engaged in this right away. And I think that
Mhm.
that was surprising, because one of our asks is, if there is a disruptive behavior incident, no matter whether it's name calling or it's threatening or throwing things, no matter what level the disruptive behavior is, it should be addressed with the patient, and expectations should be set. And so that conversation, people find that really hard to have. And I think
Mhm.
they to it, and that's a very important step to set, to be transparent around it with the patient, that this is how we behave in the clinical setting, and what's reasonable. And so I think that that's been challenging for our patients, for our staff.
Mhm.
They've also found the other thing challenging is like how to document this in the EMR.
Yes.
What to say when a disruptive behavior happens? How do you write it in the medical record? And so we have developed tools like smart sets that they can, with drop down options, so it's easier for them to say, yes,
Mhm.
the patient said this and I had a discussion. And so it helps them through that.
Okay. I was going to ask about the biggest learnings. Those are what you just shared are learnings, obviously. Um, what have been the learnings around, you mentioned a little bit about educating staff.
Mhm.
Is it just a matter of time and experience? I mean, obviously, well, first of all, of course, no one wants a disruptive patient. No
Yeah.
one wants to have that experience. But I'm certain um, there have been individual patients who have been disruptive with individual providers, individual clinicians, and other staff. So obviously, if this hasn't happened to a particular individual, then when it does happen, it's a new experience, right?
Mhm.
So part of the challenge probably is that unless sadly someone is experiencing this more than once, usually it's a new experience for that individual each time, right? So is there, do you feel that the tag team has become very skilled in being able to immediately say, Dr. Smith or Nurse Jones or staff member Robbins, yes, this is what this is. We're going to take care of this. In other words, they've probably become highly skilled in managing this, right?
Yeah. It's a complicated question, and I try to break it down. And
Mhm.
this is a culture shift, because we in healthcare, we have been programmed to serve, and to, our ED nurses or our nurses on the floor, they have taken so much of disruption from patients that some of it is normal to them. And
Yeah.
so they may not necessarily feel that they have to report this, because they think this can happen again tomorrow, and that's part of their job. So I think that culture piece is important. And I remember that a couple of years back, our CEO came to one of our staff meetings in a clinic and said, this is not okay. Dealing with disruptive patient and you being abused by disruptive patients is not okay. You have to report it. So I think our leadership has played such a significant role in empowering our staff to to speak up when this happens.
Right.
And and yes, again, like once we hear about the event, the threat assessment group takes over, and then we are, one of our biggest goals is to communicate. So we make sure that the person who underwent that episode, the staff member, we reach out to them, we offer support, we offer employee assistance program or a leave of absence, or depends what
Right.
resources are
Right.
needed, but
Right.
there we communicate. Yeah.
Exactly. One of the things you said just now piqued my curiosity. I know that nurses have to deal with all sorts of behaviors among patients. So is it possible that nurses might feel that certain incidents or encounters are gray areas and that's why they might not report them? And so is a part of it um, trying to come to a to a consensus about what what a base level disruption is? Has that been discussed? For example, one nurse, let's say there's nurse A and nurse B, and nurse A would right away say, oh yes, this is a disruptive patient. This is a disruptive situation. And nurse B might say, oh, I didn't even realize that you might think that, because to me, this seems somewhat normal. Have you had to kind of parse that for people?
Yes. Well, so we've broken down disruptive behavior into 3 levels, and
Okay.
level 1, we are teaching them about that it is a disruptive behavior that can be de-escalated. So it could be a patient who's yelling at the front desk, but it can be de-escalated. And then there is level 2, where let's say the same patient yells every single time. So this is a trending behavior that is not acceptable and cannot be further de-escalated.
Right.
Or this turns into inappropriate comments or touching or any
physical throwing things. Yeah, right.
Yes,
right.
Or coming intoxicated.
Right. So in the case of the first situation where it's just a patient yells once, and say it's at the front desk, as you mentioned, and the front desk, the person sitting there is able to de-escalate it, does that lead to a report, or does it not lead to a report?
Yes, our expectation is that all levels should be reported.
Okay.
And then it's up to us to further decide how to triage those cases.
Okay. So if, let's say, I'll just make this up. Let's say a person comes in and is somewhat irate and yells at the front desk. They are de-escalated, they go into care delivery, and nothing more happens. Will that patient be warned, or what is the protocol then?
Yes, very good question. And that's my biggest teaching point, that yes, at that point, or at another appropriate point, this should be discussed with the patient, that this is not, most patients just need just a one-time conversation, and behaviors don't repeat after that. Okay. And especially if the provider with whom they have a relationship, the provider says to them that, Mark, this is just not like you, what happened that day? And that would really take care of things. So transparency and setting expectations is important.
Right. Now, would that, if it were a one-time situation and it were not, and there was no actual violence, someone just yelled and said, you people are terrible or something like that, would that be flagged then in the EHR?
No. So for flagging, we have a criteria that the patient has to meet, and that we have a policy around it, and it's generally it has to be a trending behavior. Like the purpose of the flag is for us to be prepared for the next visit. So once the flag goes up, along with it, a safety care plan goes up in the EMR that says this for next appointment, make sure public safety is in the room or in the hallway, or offer this patient only male provider, or care for in twos or in pairs. So we have a plan for next time. So generally it has to be a trending behavior that we expect to happen again.
So that's terrific that you then have a plan in place. So patient X was disruptive once. Patient X comes back a couple months later for a follow-up or some other issue. And so when patient X arrives, it's already in the system. So even the front desk person will know that this is a flagged patient. Yes. That's really
Our
great.
goal is that we would huddle in the morning to see if there are any patients with a flag that are coming in. So we would be ready. And our public safety officers would be ready as well.
I see. Okay. How do you feel that things have been pretty successful then overall?
I think so. We've had a lot of cases in 2 years. Even though there were very serious threats made, thankfully we've not had an actual incident where
there was physical violence, right?
Exactly, got carried out. And we've been successful we've transferred patients from one clinic to another clinic. If the setting wasn't right, we've reestablished them with a new provider, set a behavior contract, and they've done really well in a different setting. Some of our patients are now seen in a special setting where the primary care doctor is also a psychiatrist, and the appointments are done in a controlled setting where the public safety officer is in the room. And some of this group of patients, we've transferred them back to traditional primary care. So our goal is to use whatever resource we can to accommodate and to provide a setting where the patient is likely to succeed.
Wonderful. What would you advise others who might be, I mean, this is a model program, I think, and others might want to copy. I'm sure they might contact you, of course. But besides that, what would your general advice be for those who might begin moving down this path?
Yeah, I think if you don't have a program like this, I would say start now. Don't wait for something to go wrong. I think that's important. And most people will be surprised, like we were, that you have all the resources in place, but you are just not using them together to respond to an imminent threat in a timely manner. And
so it has to be made systemic then. Is a key.
Yes. Yes. Yeah. Creating just standardized workflows where everybody knows what their role is, whether it's the medical director or the patient safety leader. They all need to know what's their role in the situation.
Yeah, absolutely. And do you feel that your team, including clinicians and non-clinicians, feel better now? Do they feel more secure? Do they feel safer?
Yes, they do. And it is so encouraging to hear the feedback from them, because in the past there was no such system. And now we are with them. We are constantly communicating with them if there's an issue around imminent threat. And it's comforting, and they're not as scared or feel alone as they did previously. So
exactly. Good. Any final words?
Well, I think my final word would be to not forget why this is happening. This is these are not bad patients. They are being triggered by really stressful situations, and most of them have psychiatric illness. So I think just remembering what is the underlying cause and how do you support this vulnerable group of patients, and using all resources to do that. That should be the vision around this.
That's wonderful. Dr. Seth, thank you so much. This has been extremely enlightening. I know that our audience will appreciate it very much, and I'm quite certain people will want to try to create a program that's more systemic. My guess would be, as you said at the beginning of your journey, you had pieces of this in place, but you didn't have a full program. So I think becoming systemic is absolutely key. So.
Thank you. My pleasure. Happy to help if anybody wants to reach out. Thank you.
Great. Thank you again. Thank you so much, Dr. Arshiya Seth, Cambridge Health Alliance. We really appreciate it. And this concludes our session. We will see you again, and have a great day.